Hello everyone, welcome back. I'd like to welcome you to the next section of the program. We're going to be talking about SNOMED's role in the EHR. So I'm going to do a bit of swapping with Anna. We're going to show some demonstrations. And the focus is the role of SNOMED CT in the EHR, how it can support clinicians and clinical data. We'll talk about how it's a clinically focused language that can help present a meaningful view of data. It can help support the easy and accurate documentation, and SNOMED can support research and decision making. SNOMED CT is the global clinical terminology that adds meaning to electronic health records. As the clinical terminology of choice for EHR systems throughout the world, the clinical knowledge within SNOMED CT is increasingly being used to contribute to the quality, consistency, and safety of healthcare delivery. In order for SNOMED CT to support clinical documentation in electronic health records, it requires a broad scope and a high level of expressivity. However, on its own, SNOMED CT does nothing. To realize the potential healthcare benefits, it needs to be an integral part of a well-designed EHR system. So clinicians use SNOMED through an EHR, and the user experience and the level of integration is really determined by the EHR implementation. So looking at the kind of high-level architecture, when designing an electronic health record system, in addition to the core health record data store, which is used to store the patient data, we recommend including a specialist terminology server that can provide functionality related to clinical terminologies and can be used to support the health records. A SNOMED CT-enabled terminology server holds the terminology content, and it provides terminology-related services that can be leveraged by the EHR. There's several off-the-shelf terminology servers that specialize in SNOMED CT and support SNOMED queries, and this can greatly reduce the effort of implementation, while also enabling best practice implementation of SNOMED and functionality like user search, clinical decision support hooks, and meaning-based queries. It is possible for some basic use of SNOMED CT through importing SNOMED directly into generic software applications using flat lists. But this approach cuts off the semantic network, and it usually makes updating content harder. It really prevents organizations from realizing the potential value of SNOMED in their systems. We suggest a service-oriented architecture where a powerful terminology service can be provided using pre-built tooling and using standard APIs like HL7 Fire. SNOMED International has an open source Fire terminology service that specializes in SNOMED CT, and there are some strong commercial products available. This way, terminology services can be reused in multiple clinical systems and can be updated and maintained independently of them. A terminology server can be used to more effectively support the key EHR functions. And this is the role of SNOMED CT in the EHR.
Stop share. Oh. Okay, I'll just continue here. Thank you, Kai. Am I sharing? No. have now? Yeah. Okay. So this may seem like a bit of a technical background for this session on SNOMED in the EHR. And with you as a clinical audience, I just want to say a few words about why you have to bear what Kai just said in mind. And that's because what is important for you as a clinician to understand is that SNOMED CT provides the content and it's provide the technical resource that is required to make the electronic health records friendly for clinicians and useful for clinicians. But the only way that they can, as Kai said, make SNOMED CT an integral part of a well-designed electronic health record is by the input and assurance from clinicians that the systems work as it should be. So the point about SNOMED CT not being anything without being implemented is really, really true. And clinicians play a very important role in making that a success. So this session here about SNOMED in the EHR, from your perspective, should really be about hopefully triggering some thoughts about, well, what is my role in this and how can I contribute to the success and to us achieving the goals we want with SNOMED? So you've seen this earlier today about the requirements for a clinician, and I want to dive a bit into this with a focus on these requirements in an electronic health record perspective. So clinicians want to record using a clinically focused language. Let's start there. So as you saw earlier, it is in SNOMED CT possible to have different terms, and we have the range of concepts in SNOMED CT. So it can be considered as a global language for health. However, one important feature is that SNOMED CT does not dictate what it is you should say and how you should say it. The design of SNOMED CT just supports the fact that you can have multiple synonyms available. As you remember with the heart attack, you saw all the different terms that were associated, and the same for endoscopy. So the design of SNOMED CT supports a clinically focused terminology because it have the feature to specify multiple terms that are required by clinicians. But exactly what those terms look like and how they are, that's you with your clinical knowledge that should support and come with input to how these terms should look. So SNOMED CT provides the means to specify the terms, but we don't dictate what the terms should be. And this is really where the current terms in the international edition comes from clinical requirements and user input. So in terms of being a clinically focused language, it goes beyond just talking about terms. It covers also the breadth and the detail. And this talks about, or this speaks to the point that SNOMED CT has the comprehensiveness, so the breadth, all the various hierarchies, and also what I told you earlier, that there's no limit to how detailed you can be. So the breadth and the depth is also determined by clinicians. So in order for SNOMED CT to be clinically focused, it needs the design that it supports the extensibility when it comes to the breadth and the depth. For a clinician, there are multiple objectives for data recording, being able to record signs and symptoms, test results, general observations, medical history, social circumstances, family history, diagnosis, procedures, functions, abilities, medications, care and therapy. So these are just some of the different types of information that you will capture in a health record or some of the surrounding systems. So this is, in order to have a clinically focused terminology, you need to be able to cover all of this. And let us just take a look through an example of a patient journey through the emergency, through the tests and investigations that are performed at a hospital, to the process of care and treatment, to medication and rehabilitation. Information is captured. It starts when the accident happens or the disorder is identified. But with SNOMED CT, you can collect data from each of these various disciplines and specialties, and it could can be collected at the different levels and details of precision, and it can be reported to a central data store, and that will allow you to obtain what we'll talk about later, also clinical overviews and being able to have the complete picture of the patient journey that is required to make the best possible care and treatment. SNOMED CT evolves. So when we talk about the breadth and the detail, that can change over time. So in SNOMED CT, we add new meanings when these are required. So we have, and you'll also hear from Maëlle later about how it works with the French extension. But the design of SNOMED CT is so that if there are gaps of any kind, these can be requested for inclusion, and then they can be added. It may also be that you have seen how concepts are defined in SNOMED CT via relationships to other concepts. And if there are some things that can be made even more accurate and precise, and you want to refine some things, then those types of changes are also possible. And then there are also the idea that no concepts in SNOMED CT should be overlapping in meaning or duplicate in SNOMED CT. So we also inactivate meanings when they are no longer recommended for use. It can also be that they are outdated. But one thing for sure is that we never delete things in SNOMED. So you can be completely sure that if you record something using a SNOMED CT concept, in 10 years from now, you won't ever find that it has disappeared. You will still be able to trace it. SNOMED CT support full history tracking and traceability over time. Another requirement for the clinicians is the right data at the right time being available. So, as I was talking about earlier, well, introducing EMRs or electronic health records, isn't that enough? Isn't that sufficient? No, it's only part of the solution. In order to be sufficient and to deliver the right data at the right place and the right time, you need to be able to create these meaningful views of the clinical situations or clinical overviews. So let's look at an example of a patient, Robert, who while walking the dog one day, he suddenly falls. He loses of consciousness, and he was dizzy, and he had chest pain. So a person finding Robert on the street is calling the ambulance, and already in the ambulance, the clinician starts to document these signs of loss of consciousness, dizziness, and chest pains, because Robert has slowly awaked and he's able to express these things. And in the ambulance, they already start to measure, to do the key measurements of pulse, of oscillation, and blood pressure. So the starting tests already starts in the emergency, and this actually impacts the journey for Robert and the treatment for Robert. At the hospital, further tests and investigations are performed, and there's transthoracic echocardiography performed, and this shows that Robert has a severe aortic valve stenosis and a left ventricular hypertrophy. So, and he's also fit for, or his circumstances with age and how he physically is fit makes him suitable for a surgical procedure of the replacement of the aortic valve. So already here at this point, look at the things that have been performed. These informations of the signs, these cardiovascular findings that are measured in the emergency room, the tests and investigations that leads to diagnosis and the planning of a procedure. And then after the procedure, a summary, and before he is discharged from the hospital, the diagnosis, the summary says that he had these diagnoses, there was a surgical procedures, and he's also giving some medication to monitor or for his blood pressure. And then he goes home and he's of course followed. And at follow-ups, it's important for the clinician to easily get a picture of what happened to Robert, because aside from Robert, you have many patients coming in and out of the clinics every day, or the hospitals. So it's very important for the success and for the efficiency and for Robert to feel that the clinician that he sees really understands his situation, that the clinician can get the overview. So if we have a system that is fully enabled using SNOMED, you can capture all of these information using a single terminology, and you can use a single terminology to then display and retrieve and then display the information to get a meaningful overview. Let's continue the example by looking just at some concepts in SNOMED. So this actually represents Robert's journey. You can see we have the clinical findings that was reported as signs and symptoms: dizziness, loss of consciousness, chest pain, a slow rising pulse, heart murmur. Then there was also some disorders identified: the left ventricular hypertrophy, the severe aortic valve stenosis. A range of tests were performed: auscultation, blood pressure, replacements of the aortic valve, and transthoracic echocardiography. So we have them all represented in SNOMED CT, and this makes it easy for the systems to say what procedures were performed and what diseases were found and what findings were identified. So the systems will be easily in a position where they can be able to easily create the overviews that will provide some value for the clinicians to get an overview, for example, for a follow-up. This is what we mean when we say a meaningful view. In the introduction, we said that SNOMED CT represents meanings by having these defining properties. And why do we have that? Well, it is in order to be able to create these meaningful views for clinicians, so that we can show maybe all allergies of a patient, or show the test results and examination and findings, giving an overview of diagnosis and procedures. Or maybe in a clinic or in a ward, you are able to monitor the infection numbers for the patients that are admitted in the hospital, so that you can monitor the level of infections over time. It depends on what the requirements are in the clinic. So next, the requirement is that documentation should be fast, easy, and accurate. So let's talk a bit about data entry with SNOMED. So we've already talking about terms that should be easy to understand and recognize. Then it's also an important requirement that you should not display meaningless codes and symbols. SNOMED CT comes with a range of numbers, but these numbers are for the computers. They are not intended to be displayed for clinicians. So no clinician should go and remember codes. They should just speak the clinical spoken language. And then an important part for data entry with SNOMED is that only relevant options should be available. You have now heard how big and comprehensive SNOMED CT is. Well, a key implementation aspect is that you make sure that it's only the relevant options that are available at a certain time. And then it's important that when SNOMED CT becomes an integral part of a well-designed EHR, that the end user is involved in specifying requirements for data entry. So how do you want the user interface to look? How do you want things set up? And what are the overviews you need? That should be determined by clinicians. This just speaks to the point that we've already addressed, that there are different terms, but because the terms are associated with a single concept, it allows multiple different user interfaces to use different terms while still recording the same concept code. That is important for storage and retrieval. And even in some systems, you may allow free text to be entered, and then natural language processing tools can be implemented to support the identification of the correct SNOMED CT concepts to use for storage. This, of course, requires some human validation of the identified codes. So the key principles is that SNOMED CT in the user interface should hide the identifiers, and they should use the terms that are familiar to the users, because the codes doesn't make sense. This could be a very bad implementation where you have the codes, and that would not be very helpful for a clinician. You need to show the terms as you have it here. The codes are used and important, but not for clinicians, but for query and exchange. So it's important that the identifiers are stored. So that's also a requirement. And then the relevant options, which is probably one of the key implementation principles, is that we shouldn't give clinicians access to the whole of SNOMED CT. Imagine looking through 350,000 concepts every time you just have to find an allergy to penicillin, for example. No, you need to constrain it to mitigate the risk of capturing unintended meanings and make it easy and fast. So when you implement SNOMED CT, depending on what type of information you're trying to represent, you should constrain the input fields to specific parts of SNOMED CT. And it may not only be whole hierarchies, it can be parts, even smaller value sets. And here you just see how some of the top level hierarchies in SNOMED CT are designed for or intended to represent information for some of the key types of inputs. So about the visual design, just as we don't dictate what terms to use in the user interface, SNOMED CT does not dictate how the user interface should look like. Again, this is where clinicians play an important role in the implementation of SNOMED CT, that they should assist that the user interfaces fits their needs, and they should be good at specifying this is how we want the input data to look and the output overviews. And be open to the fact that things may change when you start to move from unstructured to structured data entry. So these input fields can be whatever. The one thing that determines what type of input field that you can use is probably more the number of options you have for selection. So if you have a range of diagnoses to select from, you may want an input field where you can do a sex search. And then how you constrain that set can either be determined by a rule, for example, all the diseases or all the surgical procedures, but you can also specify manually, we want these 50 codes to be searchable in this field. So this shows just an example that you can constrain a field. So for a diagnosis field, you want to exclude anything that is not a diagnosis. So you would, in SNOMED CT, include the subtypes of the concept disease. In a procedure field, you wouldn't want to be able to record body structures or diseases. You want to just record procedures. So you should constrain that field to procedures. And again, this is a clinical implementation role that you're able to specify what are the correct types of meanings that we can capture in this field. And SNOMED CT and the implementer should then assist in defining those rules. So the clinical requirements should come from the clinicians, and then the SNOMED CT specific, this should be transformed into a SNOMED CT specific requirement. So this will talk a bit about why is it important to constrain? Why can't we just give clinicians free access to the whole of SNOMED? And they actually tried that in the UK some years ago, and it turned out to be a bad idea. So in this example, I just want to show that if you do a search in SNOMED CT for concepts such as malignant melanoma, if you use the SNOMED CT browser, you will find that there is numerous concepts matching on malignant melanoma. And not all of these concepts are sufficient to use for recording a new or current diagnosis. The first concept up here is not, even though the term is malignant melanoma, it actually represents the morphologic abnormality, which is not a diagnosis. It's the abnormality at a cellular level. There's a concept called history of malignant melanoma. Again, that's not a current diagnosis. It's something representing a past history. It's not a current diagnosis. Another concept could be the family history of malignant melanoma. And that's, again, it's not related to the patient. It's related to some part of the family. So although these three concepts match on malignant melanoma, they shouldn't be included in a place where you would record a new or current diagnosis. Whereas this last concept, malignant melanoma, the disorder, it sits in the disorder hierarchy and represents a disorder of type malignant melanoma. And in an implementation, you may even want to specify one of the subtypes of malignant melanoma, for example, if it's on the chin or if it's on the nose or shoulder. There are concepts in SNOMED CT specifying the exact location for these malignant melanomas. So in the UK, I told that they have been trying to do that unconstrained data entry in an emergency room. And this just shows you how the wrong hierarchy can unintentionally be used. And it's not because of a clinical mistake, because you can actually see that the search term that they have applied in the first case, temperature, match on a concept temperature. But this is actually an attribute, so a relationship type. It's not something that is intended to be captured in a clinical record. And a high temperature, you can imagine a patient coming in with fever and the clinician search for a high temperature. That will also give a match in SNOMED, but this is a physical force. So the actual force of having a high temperature, it's not a finding of a high body temperature or a body temperature, an increased body temperature. And if you go here down to alcohol, you can imagine a patient coming in with alcohol intoxication, and you have searched for alcohol. In this case, you want a concept representing alcohol intoxication and not the substance alcohol. This just represents the substance. So in all of these cases, you have many occurrences of incorrect use of SNOMED. And it's not because of clinical mistakes, but it's because of bad implementation. SNOMED CT, in order to be successful, needs to be constrained so that when you have a place where you enter signs and symptoms or findings, it should only be those concepts that are selectable. Yeah, this speaks to the various different types of controls that can be used. And SNOMED CT supports whatever type of control you want to use. I want to show you a bit of data entry before we move on to data retrieval. I want to just jump to a demonstration user interface. So we have this tool here that is a demonstrator of best practice principles for recording information using SNOMED CT. So it's just a dummy system, a front end. But here it shows how some different screens that could be part of an electronic health record. Here's a screen capturing patient details. Some of these fields have a blue S, and these are the fields that use a SNOMED. So this also shows that it's not all fields where it's relevant to use SNOMED. For example, patient ID and the name and the date of birth, that is not something you would find in SNOMED. We don't have all names and addresses and stuff in SNOMED. But the things like the gender can be represented. And here you see it's only a few options that have been pre-selected. So there are many other gender concepts in SNOMED, but in this implementation, it has been decided these are the gender concepts we want to use. And you don't see any concept identifiers, but this is a demo tool, so you can unfold this eye here and you can see these are actually the concepts that are stored when selecting. Down here we have another field, another drop down where you can see that there are some smoker options for the smoking status. If I go into the encounter, you see some fields here with S as well. And this is where you can document the reason for encounter, the diagnosis, and the procedure. And each of these fields have been constrained. So in this field, it has a very large value set. You can search across all procedures, findings, situations, and events and stuff. So maybe this patient came in because the patient has a pain in the abdomen. And you can see I just start to type and I do just a substring. So I don't have to type in anything. I just start to type and then the system will show me the results and I will select the one that matches in this case, abdominal pain. Then some tests and investigations may have been performed, and we find that this patient actually have an appendicitis. Again, this field has been constrained to only clinical findings. So as a user, I can be sure that I'm not searching for across physical forces or procedures or anything. I'm just, when I start to type here, the things that I will see are all types of clinical findings. And I'll search for appendicitis, and you can see here, I get some different options. Is it a mass of the appendix, which is a finding? Is it that the appendicitis, or is it a hematoma? All of these matches my search string. This procedure field has been constrained to only procedures. So let's try again to say appendicitis down here. And while you can see that I get a match on my search string that I also applied in the diagnosis field, you can see that the results that I have here are all types of procedures. So now I can say appendectomy. If you notice over here, the laterality field is disabled. And that's because an appendectomy has a finding site of the appendix structure. And that's not lateralizable. We don't have a left and a right appendix, or the appendix structure itself doesn't have a left and a right side. It's non-lateralized. So let's say instead of the appendicitis, it was some kidney disease. Let's say we have a kidney stone. Renal calculus. And maybe we are doing some renal, I don't know if there must be some removal. Ian, is a calicum, is it where you remove the renal stones?
Calicotomy.
Is that where you remove renal stones? Okay, so that is what we do. Yeah. And so now I selected some procedure, and I didn't even know that this is what it does, but Ian has confirmed with his good clinical background that now we're removing the renal calculus. And now you can see the laterality field has been enabled because the renal calicotomy, that is a procedure that is performed on either both or the right kidney or the left kidney. And this procedure has been defined with a procedure side of the renal structure. And our kidneys, because we have these are lateralizable because we have a left and a right. So we have a subset in SNOMED CT where we specify all those body structures that are lateralizable. And this is a very important subset because it enables us to easily help the clinician not to do something that is lateralize something that is not lateralizable, but also identify, well, yeah, we need to specify a laterality in this case. If we instead had chosen, for example, let's not consider the renal situation, but if there was something with the hip and we want to do a hip replacement. So we could do a total replacement of hip. The same would occur. We can still do select because we have either the left hip structure or the right hip structure. Some concepts in SNOMED CT have already been defined. And here you can see the left nephrectomy. Let's do that. That's back to the kidney stuff. So left nephrectomy, you can see that it pre-populates the left because left nephrectomy has been defined also with the laterality of left. So now we are not able to say left nephrectomy with the laterality of right. So again, we use that subset and we use the defining properties of SNOMED CT concepts to help us have some intelligence and some documentation support. So this is an example of how we can use SNOMED CT for data entry. And please notice that we haven't seen any concept codes. The terms that we have used for inputting data has been clinical terms. It has been my attempt to try to do a search in SNOMED CT that has led us to this result. Because this is a demo tool, you can see when I hover over it that there is a SNOMED CT code behind it. Yeah, so that was how SNOMED CT supports data entry. And in the next part, we're going to look at data analysis. And I will hand over to Kai.
We wanted to do a half-hour discussion.
Sure. The demo, the link to the demo.
And all stuff
Yeah.
UI.
Yeah, you can put chat.
Okay, hopefully you can see my screen. I'm going to talk about how SNOMED CT can support clinical research, and in turn, that can support decision making. So coming back to our ideal cycle of data and knowledge, we're going to dive into how SNOMED supports queries and data analytics as a foundation for research. So SNOMED concepts are organized into a hierarchy structure that reflects the meaning of each concept. And this is a polyhierarchy. A concept can be organized into many categories, or if we think of a hierarchy, it can have many parents in the hierarchy, and this reflects its true meaning and it reflects reality. Representing clinical knowledge in this way enables powerful queries that have many uses in research and in the EHR. We're looking at the example of pneumonia, which is a disorder of the lung. It is an inflammatory disorder. We've got four more disease concepts here. And this is a simplified version of an extract from SNOMED. There's actually many more levels. But if we have clinical records that use these concepts and these disorders, we can make selections in many ways. For example, if we want to find patients that have any type of inflammatory disorder, we can use the hierarchy and these semantic relationships, and we will pick up each of the colitis, appendicitis, pneumonia, and bronchitis. So we can easily identify patients with those disorders. In another example, we may want to identify people with any type of respiratory disease. Again, the hierarchy can be used. There's a section for respiratory diseases, and by navigating down the hierarchy, we can identify all the concept codes that are relevant, and in turn, those can be used to match the clinical records and identify those patients. We can do many more examples. For example, we can test if a patient has any disorder of lung. There's a patient down here in green who has appendicitis. And of course, the terminology server can tell us by looking up the hierarchy that appendicitis is not a disorder of lung. And this can be useful if we need to trigger decision support rules. There are other types of relationships in SNOMED. For example, it's common for disorders to have a finding site relationship. These, of course, are linked to body structures. And it's also very common for disorders to have associated morphologies, how the body structure has changed. For example, an inflammation or a dyslipsia, fibrosis, or abscess. All of these links can be used in queries, SNOMED queries. So let's take a look at a data analytics scenario that leverages the SNOMED CT hierarchy to do clinical data selection. We're going to look at assessing treatments and how effective treatment options are at preventing certain outcomes. We have a scenario here concerned with breast cancer and the BRCA1 gene mutation. So we're considering a patient cohort who have had the gene mutation test and have tested positive, and we know that they're at an increased risk of cancer, and it could be breast cancer. There are some treatment options available. There are some drug prevention treatments, and we also know that they've got severe side effects. So the question is, do these, how effective are these treatments? Do they significantly reduce the risk, to try and establish if it's worth the side effects? Of course, a clinician wants to be able to provide advice, and the research needs to happen to gain the medical knowledge to provide that advice. So in the research scenario, we're interested in a specific cohort of patients. These are the patients with the BRCA1 gene mutation, and we can do some kind of mathematical set theory here to measure the correlations. So the patients who are taking the cancer preventative medicine, we want to see what's the correlation with a diagnosis of breast cancer. And similarly, for patients not taking the preventative medicine, what is their correlation? And we can use SNOMED to build up the queries. So for the people with the gene mutation, in SNOMED terms, we want to find all the concepts that are subtypes of the BRCA1 gene mutation positive. And the SNOMED query for this looks like that. And again, for the other groups that we're interested in, we have a SNOMED query. It's not easy for the breast cancer preventative medicine because there's not a single concept that is a grouper for those medications. So we may need to build a small subset. These examples of tamoxifen and the other two are taken from guidelines in the UK in the NHS. So these are the SNOMED queries that use the SNOMED knowledge graph to find the relevant concepts for this study. We can show them on the subsets here. So I'm going to switch now to the data analytics demonstration tool to run through this scenario. I'm going to start in the subset area. So we've built a subset for the breast cancer prevention medicine. So this includes all the descendants of the products containing tamoxifen, and there may be many drugs containing tamoxifen. And we've got two other drugs here. So we can run this query, and we find in the international edition, there's 18 matching drugs. In a national extension of SNOMED, it's likely that there'll be many more branded products. They would all get selected automatically using this query. This analytics tool has three main functions. One is treatment comparison that we'll be looking at now. There's two others for comparing the effect on establishing the groups of patients who are most at risk of various diseases, and to look at longitudinal studies and trends over time. So I'm going to go into the treatment comparison function. We have a generated data set. It's synthetic data, but the records within the data reflect what we've seen in patient records in hospitals and also in published research papers. So I'm going to build the patient cohort that we're interested in. And from our 1 million patients, we're interested specifically in females who have had the test, the BRCA1 gene test, and they've tested positive. And it's around 1,000 patients in this cohort. The outcomes that we're interested in, there's only one. It's breast cancer, malignant tumor of breast. And before I define any treatment options, I'm going to start by looking at everyone in the cohort. And we can see that for this cohort who have tested positive for the gene mutation, the correlation with breast cancer is very high. It's around 78%. Now we're going to introduce some treatment options. There's one, it's the breast cancer preventative drug. Oh, yeah. So this is actually selecting the subset that we created, the query that picks up all the relevant drugs. And I'm going to create a label for the graph. Prevention medication. And I'm going to run the report again. So we can see that this has a dramatic effect on the outcomes. The patients who are taking the preventive medication have just a 30% correlation with breast cancer. And these are subsequent outcomes. So it's important that the tumor of breast is being recorded on the record after starting taking these medications. And it's around 30%. And for the patients who are in this group with the gene mutation, who are not taking the medication, the correlation with breast cancer is really very high, around 73%. And it's important to note that it looks simple, the selection of malignant tumor of breast. That's a very general concept. If we look into SNOMED CT, there's actually over 170 different types of malignant neoplasm of breast that can be recorded, and they are for different quadrants of the breast, various ducts, and different types of infection.
Yeah, so the point about that is that in the clinical record, the clinician could have been very detailed when capturing exactly what they wanted to represent, which will be recorded and can be viewed in the patient's electronic health record. But then for analytics, you may want some different level of aggregations that Kai just showed you. But it can all be done without even having to know a lot about SNOMED. You just have to use the terms again to search for the things that you're looking for, any kind of malignant tumor breast, essentially, and then you'll get everything.
So this is the start of this piece of research. But if we have the data, we could run the report again and again on different quadrants, different ducts, see which medication is most effective. We could look at different age groups. We could check if they have a family history of breast. There's lots of possibilities. So new knowledge gained through analytics and research can be fed back into the start of the cycle. We can provide new knowledge to clinicians and nurses, and they're always learning. We can also use the new knowledge that's gained to enhance the clinical decision support systems that supports all the healthcare staff. There's many types of knowledge linkage and decision support facilities that can be supported by SNOMED using the knowledge graph. Let's look at, I'm going to skip the examples because we're very short on time. But typically, alerts and reminders can be presented when relevant disorders or conditions are recorded. relevant clinical guidelines can be presented. And it's really important and really essential that a good user interface and user experience is designed so that these things that kind of pop up on the screen really complement the user experience and don't provide a distraction. The last part of this presentation is about another demonstration. During 2023, I worked with the Barmany organization, and they maintain an open source EHR system that's used in digitally maturing countries, including many areas of Africa. And the project was to integrate SNOMED CT. We started with implementing best practice data capture to get some high quality data structured. And we built upon this to develop some valuable features, including some clinical decision support rules for drugs, and also some interoperability and data analytics capabilities. I'm going to run a short video to show this.
SNOMED International.
Not sure how to do this without an echo. You try.
SNOMED International and the Barmany Coalition, a group of organizations that contribute to develop or implement Barmany's open source electronic medical record, are working together on a SNOMED CT module for integration with the Barmany EMR to provide structured terminology openly and digitally.
Pardon? I'm not sure how to do it. Going like mad. Okay.
You put it on.
That use, contribute to develop.
Is that going to work?
SNOMED International and the Barmany Coalition, a group of organizations that use, contribute to, develop, or implement Barmany's open source electronic medical record, are working together on a SNOMED CT module for integration with the Barmany EMR to provide structured terminology openly to digitally maturing markets. In this demo, we are simulating a clinical visit. We start by selecting a patient from the list. It's a 65-year-old male with asthma, hypertension, and hypercholesterolemia. He presents to the visit with palpitations and fatigue of recent onset. We will use the history and examination form to record this information by selecting terms from SNOMED CT, powered by Snowstorm Lite, the integrated terminology server. In the consultation panel, we can enter a free text clinical note describing our reasoning. The electrocardiogram results showed atrial fibrillation. We record this primary diagnosis in the next panel, searching in SNOMED CT. The next step is to prescribe the necessary medications, beginning with dabigatran, an oral anticoagulant, to reduce the risk of stroke in patients with this condition. The medications panel uses the terminology server to search SNOMED concepts for the available medicinal products. The clinical decision support system has identified a potential interaction between dabigatran, the medication newly prescribed, and aspirin, which the patient has been taking until now. This interaction was detected using an interactions knowledge base developed for this project, and using the terminology server to compare with the medication ingredients described in the SNOMED concept attributes. We are also prescribing propranolol, a beta blocker to manage the rhythm and alleviate symptoms. Propranolol triggers a different type of alert, a contraindication in this case due to the patient's chronic asthma. This alert enables us to revise our decision and prescribe atenolol instead, a similar drug that does not have this contraindication. This alert is also an example based on a custom knowledge base, which employs the terminology server to match with content encoded in SNOMED CT. Now we are simulating a data entry error. We have selected 2 tablets of atenolol to be taken twice a day, not realizing that in this system, it amounts to 4 tablets daily. A new alert informs us that we are exceeding the recommended daily dose. This alert is triggered by a knowledge base that uses the ATC-defined daily doses and leverages the detailed ingredient and strength attributes in the SNOMED concepts to calculate the total dose. All the clinical information recorded in the patient's history is readily available for reporting purposes. For instance, we are now going to generate a daily statistical report that includes the ICD-10 code for the primary diagnosis of each visit. This reporting feature utilizes the terminology server to access mappings published in SNOMED CT releases, a result of the collaborative efforts of SNOMED International with various organizations. For more information about this collaboration and the open source tools, please visit the SNOMED International and Bomni websites.
Right, sorry about this. Yeah, sorry about the problems running that video, but hopefully that made sense. I'm not actually able to access this system on this network, otherwise I'd do a live demo. But that concludes what we had planned for this session. Please raise your hand if you've got any questions or any questions in the room. I'd love to hear from you.